Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at Lineberger. And thank you so much for being here today, April 10th, 2019, for our RN and Allied Health Oncology Lecture. Just a few preliminaries and then we'll get started, meet our guest and begin the lecture. So if you are having any technical difficulties, please reach out to us, 919-445-1000, or you can email us at unccn@unc.edu. So let us know. You can find out about lots of different programs that we have, future lectures, past lectures, all at unccn.org. We're also on our learning portal is learn.unccn.org. We're on Facebook, Twitter, YouTube, LinkedIn, lots of places you can find out more about us. Okay. Let's go ahead and next, I wanted to mention that we have a new role that we're very excited about here at the UNC Cancer Network, and that's the role of promoter. And a promoter is somebody who is willing to take just a few minutes a month to share flyers, share emails, and really get word to their colleagues out about these events, these lectures. So we want to thank several new promoters who have joined us. Paula Berberick-Mail and Helen Colucci-Hill and Kelly Crump and Deanne Darrow and Tabitha Mebin and Jessica Rudolph. Thank you all so much for agreeing to be promoters, all from UNC Cancer Hospital. We also have Kathy Vaughn from Duke Department of Pharmacy joining us as a promoter as well. So thank you to all of you. We really appreciate that. If you would be interested in becoming a promoter, please contact us, unccn@unc.edu. Again, only takes a few minutes a month, and it's a really great way to help get word about these important lectures out to your colleagues. All right, so we will be using Poll Everywhere today. That gives you an opportunity to interact with our presenter and to answer some questions. All of this is anonymous, and then at the end you'll have an opportunity to ask your own questions. So two ways to do this, both are simple. One is just go to pollev.com, pollev.com/UNCCN. You can do this from any web browser, whether it's on a phone or a tablet or a computer. You'll see the questions, and then at the end you'll have the opportunity to ask your own questions. If you would prefer to use a phone with texting capabilities, that works fine as well. In the to field, you'll type in the number 22333, and in the message field, the letters UNCCN. You'll go ahead and do both of those things. You'll get a message back that says join, and then you can submit for the answers. You'll be able to submit those or the letters that correspond with those answers, and then at the end to text in your questions. And the first question we'll ask is, what is for you what for you is difficult about helping a patient with a treatment plan? And we will be talking about treatment plans. So if you can think of something that you found difficult with helping a patient with a treatment plan, go ahead and send that in, and then we'll take a look at that in just a moment. And without further ado, we want to say welcome to our presenter today, Tammy Allred. Thank you so much for being here.
Thank you.
Let's see, what do we know? We know that you've been an oncology nurse here at UNC since the year 2000, is that right?
That's correct.
And a chemotherapy infusion nurse with the UNC Cancer Hospital, and also worked with Lineberger Protocol Office.
Correct.
Great. And for the past 10 years, you've been as an oncology nurse navigator.
That's right.
Terrific. And worked with thoracic and sarcoma patients. Mm-hmm. And then you presented at conferences around the country regarding the importance and impact of oncology nursing.
Correct.
Great. Well, we are very appreciative that you're here with us today to share your expertise.
Thank you.
What's one thing we should know about you that wasn't in your professional bio there?
Well, so I have my fur babies, which are two miniature schnauzers.
Oh, great.
My husband and I are starting to adventure into doing stonework, making jewelry.
Oh, great. Great. Good for you. So what sort of stone are you working with?
All types.
All types.
Mm-hmm.
Well, that's great. Thank you so much. Well, let's take a look at that first poll and see if we've got any. Okay, so first thought already, complexity of regimen, change of lifestyle.
That can be very impactful. It depends on the patient's ability to comprehend medical language, mm-hmm. and as well as the nurse being able to break it down into simple terms for them to understand. So it is complex because if the nurse is not well informed about the different types, then it can be very scary. So you just got to do your research and your homework the night before or before you're meeting with the patient.
Gotcha. Conflicting schedules?
Yeah, schedules sometimes can be very cumbersome. If the patient's getting chemo and radiation, it can be overwhelming, as well as trying to get a patient scheduled for their treatment days when you're in a large volume cancer center. So you just got to, if you can, plan ahead and try to get their treatment schedule planned out completely.
Okay. Financial burden of patients?
That is one of the key things that that we're looking at now with patients is the financial burden or financial toxicities. So as being a navigator, we have to look at other sources for funding for patients, whether they need charity care or if they need pharmacy assistance. And also doing prior authorizations can be very hard sometimes and difficult to get the insurance companies to approve, but it just takes a team to get that done.
Lack of support system?
A lot of patients have nobody, have no family or very limited family, or there's a lot of illness in that family, so they feel like they're left alone. So that's where we together come as a team to help them and then seek resources. Okay.
And working with various family members and caretakers.
Sometimes patients come in with their whole family, grandma all the way down. So you've just got to somehow or another get one person to take the lead and then encourage them to talk as a family or tape the conversation so that way it can be played back.
Okay. And patients may be feeling overwhelmed?
Yes, they will. If they're not feeling overwhelmed, there's something usually wrong. Coming in, a lot of times they're just numb. So their first several visits, they will not comprehend or be able to retain a lot. So given handouts, given reminders, encourage them to keep a binder with all their information in it so they're not losing all the loose papers.
Gotcha. And this is such a difficult time of diagnosis. I thought it was fascinating. One of our guests a month ago, Zev Nakamura, was saying that simply the diagnosis it can lead to a certain amount of cognitive impairment. He was talking about chemo brain throughout the treatment cycle, but simply that diagnosis.
Right. It's overwhelming. It can numb and paralyze people.
Let's see, comorbidities along with the new diagnosis.
A lot of times patients, especially if they're older, they can have a plethora of diagnoses, not just simple hypertension. They can have a lot of other disease that would impact how they're able to receive or can they receive chemo.
Gotcha. And patients may be feeling overwhelmed as we discussed. So, all right, without further ado, preparing patients for chemotherapy, and let me pass the controls over to you there, and we'll let you get started.
All right. Thank you. Okay, so at the end of the presentation, my hope is that you'll be able to describe how new cancer diagnosis can emotionally impact the patient and their family and make them able or cause them to have the ability to interpret education that we provide them. Also discuss how to coach patients through decision making for their treatments. Recall how to effectively communicate. A lot of times when you go into a room, you're sitting there and you're just, laid back or with your arms crossed. Well, that's not going to make the patient really want to open up and feel like they can retain the information or want to retain the information from you. So it's little things that will affect the patient overall. So some of the things we're going to discuss is evaluate how patients learn and their abilities, coping with the diagnosis, education and reinforcement. So if they have handouts or DVDs or whatever education materials you can provide. Treatment option discussions with providers, because as nurses we usually find out a lot of things about a patient providers aren't privy to. Patients will open up to us more and then we can provide that on to the provider. Treatment plans, the types, whether they're chemo and radiation, or what other types of interventional procedures that may happen during their chemotherapy. and restage in time when they have their scanxiety. That is a actual diagnosis of scanxiety. Patients will get so anxious that they won't be able to comprehend how they should go through the process of getting their scans, and sometimes cause a lot of complications with their family support systems. And then last but not least, survivorship. So patient education and how to start the process. So the patient education needs to be comprehensive but easily understood. Not every patient is going to be healthcare illiterate. This doesn't mean that they can't read or write. This means they can't understand medical terms or what things, interventions you may have to get them through. So when you say a PET scan, they're going to be thinking, what is that? It just seems overwhelming. So you might have to sit down and explain to them step by step how it is. But to be able to do all this, we need to assess the patient's ability to read and write. Can they read the material we give them? What level of education do they have? Some patients have only a 5th grade education. Some have less. So we have to figure out what they need to be able to comprehend and retain and have the materials at hand. There again, can they read and comprehend directions for medications, diet, procedures, treatments? Do we need to break it down to where it's more simple for them to understand? Or is it too simple? What is the best teaching method? Is it reading? Is it viewing DVD? Is it giving handouts for them to read at home? Is it open discussion? Having other, maybe a lay navigator come and be involved? What language does the patient speak? At UNC, we have a variety of patients who come in, and we have to rely on our interpreter services. Does the patient want the basic information, or do they want in-depth? Do they want to know about the actual drugs and how they're made, or what the drug comes from, or the research that goes behind it? A lot of people just want to know the name of it and how long it's going to take for them to get it. And how well does the patient see and hear? Are they able to hear when you've given them instructions, or do you have to elevate your voice? Are they hearing impaired? Do they need to get their hearing aids adjusted? Look at the patient as a whole, not just as can they understand what you're saying. When working with the new cancer patients about their disease and treatments, it's important to give them education materials in writing or a DVD, something they can take home with them so that they'll be able to share with their family, but also they're not going to retain a lot of the information you give them at that time. They're going to be overwhelmed. So some of the education resources I found that are free is with the cancer.gov website, and also another good website where you can order in bulk is the patient resource. They have every disease process. They have if you have issues with dietary needs or image, or if they want in-depth about immune therapy, they have a wide variety of information you can get there. The cancer.gov, the chemotherapy in you covers from the beginning when the patient first comes in at diagnosis all the way through, and it's really good. But there again, you have to see what the patient's able to, their level of comprehension. So coping with a new diagnosis, as we said earlier, sometimes chemo brain, the patient will feel like they've got chemo brain when they're first diagnosed. It's overwhelming. They may feel anxious, scared. They may be in denial, or they may just shut down and just isolate the world away from them. So in those instances, we need to encourage the patient to request accurate information. For God's sakes, make them avoid Google, because you can get a lot of false information. You can get a lot of ineffective therapies, and sometimes therapies that can cause harm. Be sure they only go to reliable resources like cancer.gov or through a hospital website, something that can be validated that is accurate information. Also have them write a list of questions for each visit when they come in for the whole care team. Some may be, what kind of cancer do I have, and where is it? Has it spread outside to other organs? Am I curable? What are the possible side effects I can expect? And of course, a lot of people have heard from their next door neighbor who has a great aunt who went through a type of cancer and she lost all her hair and her teeth fell out, and they're going to think they're going through that. So we have to bring them back to what impacts them and their diagnosis. What are treatment options? Is it just chemotherapy, or can they go to immune therapy, or can they get herbal therapies? You know, there's a lot of different therapies out there. So be sure, again, bring them back to what is appropriate for their diagnosis. What tests and procedures will I need to have? You know, there again, if they talk to their neighbor and their neighbor's aunt has had all these procedures and tests and surgeries, just remember what their disease is not the same as the other person. And also, when should they call the physician? I always give my patients information who to call during working hours, after hours, weekends, and holidays, and tell them not just to call and leave a message on my phone, but to call the hospital to get the physician on call, so that way they can get immediate response. Also, keep lines of communication open. Encourage the patients to be honest, two-way communication with their families and friends. Let them know how they feel, and also encourage their family members to express with that patient how they're feeling dealing with seeing them go through this diagnosis. It can actually make a family stronger rather than tearing them apart. Prepare for possible physical changes. Encourage them to ask questions about the side effects. Are they going to have hair loss? Are they going to have nail changes, skin changes? Or are they going to have surgery that's going to make them physically changed? A good place for a lot of patients is Look Good, Feel Better. That's with the American Cancer Society. They can get makeup tips on how to cover if they've lost their eyebrows, how to cover that. Just good tips to help them understand how to make themselves feel better. And they need to encourage the patient to ask how their treatment is going to affect their daily activities. If they want to go back to work after receiving their chemotherapy, then are they going to have fatigue? Are they going to be able to do their typical workload? And encourage them to request FMLA, so that way it'll protect their jobs if they aren't able to come in on a daily basis. Maintain a healthy lifestyle. You know, it's not all eating junk food just because you're down and out, which a lot of people do that. I do that. Encourage them to eat small, frequent meals to prevent nausea and vomiting. Ginger snaps, different types of candies, ginger candy that'll have peppermint drops that'll help open up their taste buds. Eat a variety of foods that taste good. Not all foods are going to taste good to patients going through chemo. Some people have even said when they're eating meat, it tastes like it's rotten. So if that's the case, then move on, find something else that is a good protein, but that will help them be able to eat that and enjoy it. Maintain some type of exercise. It doesn't mean you've got to go to the gym to lift weights or run a marathon, but just gentle walking, whatever fits that person, whatever they're used to doing or they can tolerate. Accept help from family or friends. A lot of people think they can do it on their own. They don't need anybody to help them. But if friends and family offer to run errands, take them to treatments, prepare meals, do anything, help household chores, whatever. Encourage the patient to accept that help. Cancer affects the entire family and adds stress. Be open and honest with family and friends. Don't isolate people. Maintain as normal lifestyle as possible. If they have children, they want to go to their children's school program or go to the ball games, encourage them to do that. Even if they're on chemo and their counts may be going down, give them masks to wear so that way they can stay involved. Keep a keep a diary to reflect how they feel. Sometimes writing that down will help them be able to cope with what their emotions are and how they're feeling. And if they're faced with a difficult decision, then to write down pros and cons lists. Just all treatments can be individualized. Coping is not going to be the same for every patient. No two patients will ever do the same. There's no right or wrong answer. Be sure the patient gets that reinforcement. So words that heal, words that harm. This is something I found, and I thought, a lot of times as healthcare workers, we come in and we just say whatever comes off the top of our tongue. We need to really pay attention, because a lot of times patients in the past, or survivors, have come back and said that it really impacted them in a negative way. So some examples, a surgeon said to a man with prostate cancer who asked if he shouldn't receive radiation, he said, "Your pathology was terrible. There's nothing you can do, and that we can extend your life 1 hour." That's not very supportive, and I don't think any of our providers, you don't see, would ever do that. I don't know of any providers anywhere, but still. A nurse said to a patient receiving chemotherapy for Hodgkin's lymphoma, "Well, at least you don't have AIDS." That's not appropriate at all. So there's a list here. I'm not going to go over every one of them, but just some of the small things. The oncologist with a newly diagnosed patient, something good will come of this. Well, it doesn't mean that it's going to come to that patient. So just watch our words. I get asked this a lot of times by my patients. Myths about cancer and chemotherapy. Cancer is contagious. Not even close. But patients in the general public don't understand this. They think that, they see it in clusters like we see, but they don't understand that it's not that it's contagious. It may be that it's just that population is being hit in that one area. If you have a family history of cancer, you'll get it too. Not necessarily. We encourage them to go to see the geneticist, so that way we can find out if it truly is an inherited cancer. If they're high risk, then get them into some type of a screening, or have them see a provider to be evaluated. Cancer thrives on sugar. There is no conclusive evidence that provides or proves that sugar will make cancer grow faster and spread quickly. Eating sugar won't speed up cancer cells or the growth, just as cutting out sugar doesn't slow down the growth either. Sometimes patients come in and they say, well, the treatment's the worst part of having cancer. Actually, it is rough at times, but we can help that patient, support that patient to manage their side effects, get them in with palliative care, encourage them to reach out, let us know their side effects, so that way we can help them get through this. Drug companies and the government and the medical establishments are hiding the cure for cancer. I do not think that could ever be more wrong. There is no cure for cancer. The government and the pharmaceutical industries are not hiding it. That's the reason we have clinical trials, to find ways to cure it or to treat it. If I had cancer, I would know, because my cancer causes pain. Lung cancer is the group I work with, and many times lung cancer has no symptoms. They are only found when they come in after an automobile accident or pre-op for surgery. A lot of times there's no pain involved. Sometimes cancer patients have no pain at all. So no, that is far from the truth. Even if they go through regular checkups, sometimes cancer is undetected until like I said, they have the life-altering events. When the patient has surgery or biopsy and air hits the tumor cells, it'll spread and go all over the body. That is an old wives' tale, and it is not the truth. It's just when they find the original diagnosis, then sometimes it may already be metastatic, and further imaging will find it. It's not the fact that they had surgery.
All right, so this is our opportunity for you to answer your first question here. Which of the following statements should be given to a patient newly diagnosed with cancer? So A, don't worry about it. B, accept the diagnosis means death. C, develop open, caring, and sensitive communication with the care team, family, and friends. Or D, move on with the rest of your life.
Everybody got it right.
Everybody got it right. Thank you so much. And thanks for all the great responses at the beginning as well. It really adds to the lecture when everyone's participating with the poll.
Exactly.
All right. And you can go ahead and advance it on to the next.
So the process for diagnosis and staging before chemotherapy. A lot of times we think that it's a slow, drawn-out process, and sometimes it is, but for the most part, they may have a suspicion finding or symptoms. It may be found when they're in an automobile accident or something. So then they go to have the full workup scans. They get a referral based on the findings. They may have surgery, a biopsy, or a further procedure. Then based on that, slow down, pathology, they get the pathology and it confirms the diagnosis. Then they do further mutations, markers. They can be referred, once the stage determined, then they'll be referred for radiation or oncology, for chemotherapy, or both. And then the final step is they start the chemo or immune therapy. So the types of chemotherapy, chemotherapy is just a broad term, so there's several different types. Primary chemotherapy is the chemotherapy used as a sole treatment. Adjuvant chemotherapy may be given after surgery to attack any microscopic cells that are left behind. Neoadjuvant chemotherapy is given before surgery to shrink the tumor and increase the chance of a successful resection. Concurrent chemotherapy is when chemo radiation are given together. Sequential chemotherapy is when it's given before or after radiation. Oral chemotherapy, of course, is the pill type of chemotherapy, and we've really gone far from when I was originally an oncology nurse many years ago, when we didn't have any oral chemotherapy, and if you'd asked me then if they would have pills for chemo, I would have been very skeptical. But we've come a long way, and a lot of different diseases do have an oral drug. Hormonal chemotherapy is when the hormone therapy is treatment used with medicines to block or lower the amount of hormones that are causing the growth in the cancer. Monoclonal antibodies are made in the lab and can be used as targeted therapies to block abnormal proteins in cancer cells. And then immune therapy is a biological therapy, and it basically causes the body to increase its natural defense to fight the cancer. So components of a treatment plan may include, and it's a lot, but specific tissue for diagnosis and stage, including relevant biomarkers. I know with lung cancer, we screen for a large number of different mutations. Initial treatment plan or proposed duration. Encourage the patient to make a list of questions. What is the treatment plan? What is the length of time I will have to be invested in this? The amount of days, months that I will be through treatment. And then the provider can then sit down and discuss with the patient and offer treatment options that may meet what that patient needs. Like if they can't, they want to have as few visits as possible and be able to be at home with their family. If one treatment doesn't meet that, then maybe they can look at another treatment option. Review the side effects during treatment and their management. Be sure that the patient is aware of side effects and the ways to prevent them. And if they have a side effect and they're at home and they're not sure what to do, be sure they have someone's number to call to discuss that and to get assistance or guidance. Reinforce that not all side effects will occur. If you give a patient a handout from chemo care or cancer care where it's got the list of side effects they may have, they're going to sit there and look at that and say, "Dear Lord, I'm having every one of these side effects. How am I going to do this?" Just be sure to tell the patient and reinforce it with each visit that not all side effects will happen. Review ways to manage their medications, again, who to call, have the pharmacist come in and meet with the patient. As many people that can review this and discuss all the potential side effects and way to treat them or avoid them, the better. That way the patient hears it multiple times. If you have a young person, be sure that you look at long-term risk of treatment, fertility issues, If there's a risk while getting this chemotherapy that down the road they could develop could develop leukemia or myeloproliferative disease. Psychosocial and supportive needs. Are they financially strapped? Do they have transportation issues? Do they have ways for someone to come with them if they're going to be drowsy during treatments? And then again, do they need vocational, disability, or financial concerns? Do they need FMLA to protect their jobs? Do they have advanced disease and can't work, so do they need FMLA or do they need disability? And if they have limited needs or income, then look at all the resources that can be available for that patient. Social worker is a great person to have involved to help the navigator or the chemo nurse to find the best support for the patients. Have them tour the infusion area. I know a lot of times patients come in and when you mention chemotherapy, they think that they're going to be in a room with a door on a bed by themselves. The family can't be with them and they're scared. So when they go up to the infusion center and they see that families are sitting in the chairs with the patient and they're watching TV or laughing together, it gives them the feeling of relaxation that that's one less fear to deal with. Lay navigators are great to have to meet with patients and families to reinforce what the treatment plan can be. It's always beneficial if their lay navigator is a survivor and can say, I've been through this and this is what I did. So the more support team people that are involved with the patient, the better. Be sure to always provide written material that can be taken home with the patient. That way the patient can share with their family and they can write their list of questions for their next visit.
All right, so here we've got your next question. Which of the following should not be discussed with a patient? And if you think that's diagnosis, staging, and biomarkers, put an A. Therapy side effects, B. Treatment plan and proposed duration, C. The patient's bad life choices that might have led to cancer, D. Or potential long-term risks, E. And our audience is
smart people. They got it right again.
They're getting that quickly. All right, terrific.
Okay. So going home after they received chemotherapy. They've received chemotherapy, they're going home with their family member, and they're terrified that they're going to give that chemotherapy or that cancer to their family members. The fluids can be shared, or urines, their stool, sweat, mucus, blood, vomit, and those from sex. So it's always important to discuss treatment safety in the home when they go home, like closing the lid after they've used the toilet, to flush twice after using. It does not mean that toilet needs to be a zone area where nobody else goes around. They can share the toilet. Sit on the toilet to urinate if you're a male, so that way you don't have splashing. Wash your hands with soap and water after using the restroom, which I think everybody does anyway, but it's always good to reinforce. Cleaning splashes from the toilet with bleach wipes, Lysol wipes, or the Clorox wipes are good to keep in the restroom, and just wipe down the toilet so that way everybody is fine. Using gloves when handling body fluids or after washing, and also washing their hands after removing the gloves. And that's if they're going to be dealing with any body fluids. Wear disposable pads or diapers if they're incontinent. Be sure that they double bag that when they are throwing them away. Wash linens if they're soiled, body fluids separately. You don't want to have just the body fluids contaminated with their normal clothing. Use condoms during sex. Handling medications may be part of the treatment plan. They may have the on-body Neulasta. So if they do, just be sure the family member knows how to dispose of it and safely. Secure and control substance and all medications to keep it away from others, especially if kids are involved. Encourage patients to get even just the small metal boxes where they can lock and they'll be the only person with a key, or have them put up in the top of the closet. You don't want the chemo pills to be available where somebody else in the family can come and take it by mistake. The length of time that you and the caregivers need to follow the guidelines is important because they don't have to do it all the time. It's just whenever they're going to be excreting the chemo after they've received the drugs. Ways to manage oncology treatments. Always get plenty of rest. Encourage patients to try to sleep at least 8 hours a night, or main thing is not to take a long nap. You don't want them taking a nap for 3 hours because that's definitely going to disturb their sleep time. Limit their activities. It means just not to overexert themselves. If they enjoy cooking, fine. If they don't, then have them get takeout. Accept help. Don't ever turn down help if families and friends. I know sometimes we're all our worst enemies. We want to be the one who takes care of everything, but learn to accept help. Eat a well-balanced diet. Whatever tastes good, eat it. Stay well hydrated. The rule of thumb, as I always tell patients, is half your body weight in ounces. So if a 100-pound person needs to drink at least 50 ounces of fluid, plus 10 to 20% more, so that way they still stay hydrated while on chemo. Also, when they start to get up from a chair, encourage them to stand slowly and stand there for a few minutes to be sure that they're not having any shifts in their blood pressure, so that way they don't pass out. Scanxiety. It is an actual diagnosis or a word. Anxiety or worry that accomplishes the period of time before undergoing or receiving results from a medical examination, such as an MRI or CT scan. The way we can encourage patients to deal and cope with this is to acknowledge the feelings, acknowledge the fact that they're scared to death, the unknown that they're facing, and then have them write down a list of things. What if it shows that they have progressed? What if it shows that they responded? You know, what they're going to do either way. Sometimes writing it down helps. Talk about it to their family and friends. Vent their feelings of frustration and anger or stress, anxiety, and that way celebrate when they get a good report. Also encourage them to practice mindful living. There is a website, there is an app that they can give on the phone or on their iPad where it has like imagery and peaceful sounds so that they can relax. So encourage them to do that. Take deep breaths and breathe in the air. Or think about sitting on the beach and feeling the water wash over them. Any ways to help them relax. Distract yourself. Find ways to take their mind off of upcoming scans. If possible, read a book, binge watch comedy TV, do whatever they like doing, whether it's going out dancing, running, walking, spending time with friends, anything that will help them to get their mind off of it. And I know it's not easy, but we need to support them. Ask questions. The biggest part of anxiety is the unknown. So if they're unclear about anything, like what to expect during their scans or what they'll do if the results come in and they're negative, ask them to ask in advance what would happen, what would be able to be the next step. Plan for the worst outcome. That way they'll know just in case what the next step would be. But they encourage them to also visualize the best possible outcome. That they have 50% shrinkage, and then ways that they want to enjoy that, share that with others, and then picture that will also increase their immune system and the celebrations.
All right, so another question, and in this case, which of one of the following should a patient not do during treatment? A, limit activities and get rest. B, acknowledge their feelings. C, smoke and drink plenty of alcohol. D, eat a well-balanced diet and stay well hydrated. E, plan for the worst outcome but visualize the best. All right, how did they do?
Smart people.
All right.
Yes, we want to definitely not encourage smoking and drinking lots of alcohol. Okay, so the last slide here is resources. So places where you can get free educational materials for patients that I had reviewed earlier. Also, the American Cancer Society has a lot of good education materials. Sometimes we have to change the format to fit our patient population, but these are free resources. Cancer.net is patient education resources. There with ASCO, which is the American Society of Clinical Oncology, they have a lot of good resources there, but there again, sometimes they're more in medical language, so we might have to change that to be more where the patient can understand. Cancercare.org has supportive resources about education for chemo as well as dealing with cancer. Cancer Grace is a very good interactive website. Different types of cancer providers will have interactive discussions with patients and families, and they also provide great education. And ChemoCare is really good to get chemotherapy information where it's more on a patient level where the patients can understand without needing interpretation. These are the references I have, and this is the slide that I always put for every talk I give, and it's very impactful. It's what cancer cannot do. Cancer is so limited, it cannot cripple love, it cannot shatter hope, it cannot corrode faith, it cannot eat away at peace, it cannot destroy confidence, it cannot kill friendships, it cannot shut out memories, it cannot silence courage, it cannot reduce eternal life, it cannot quench the spirit. So we need to remember this when we're dealing with our patients, when they're fighting with dealing with the fact that they've got this life-altering disease, and we're trying to give them hope and giving them assistance in coping with this. So just remember, this is why we do what we do.
All right, Tammy, thank you so much. We really appreciate this. Let's see. We are fortunate that we do have time for some questions, so I'll go right to our question area. And I have a few to get started while we wait for our audience to share their questions. So you mentioned that some of the terminology can be overwhelming to patients. Is there a glossary of some sort? I know you mentioned some different resources that might be helpful as somebody's just starting out and getting overwhelmed with all this different terminology where they can go to
There are glossaries, but a lot of times if they would just, I encourage patients just to ask. Ask the healthcare team, ask the nurses, the CMAs, everybody that's involved in the care. That way you don't have to worry about the patient going to Google and not only finding that, but then saying, well, if I found this, let me just see what else I can find.
Right. All right, good, thank you. And how can you approach planning for the worst outcome from a patient's scan without scaring them or coming off as negative?
Okay, that's a great question. What I would encourage is that talk with the provider and talk with the patient. You might want to talk to the provider first and say, so if this shows that they have progressed, what's the next step? What is the next treatment? Are we going with further chemo, or are we going to do with radiation? What other options do we have? Because a lot of times that patient's going to come to you and say, what if?
Sure.
So you need to be prepared so that way you can educate them and say, you know, rather than saying, well, I don't know, which furthers the anxiety, give them an idea of what other options they are.
Right. Okay, thank you. If a family member with cancer doesn't want to talk about their care, disease, etc., how can someone help?
The biggest thing is you can just reinforce that you are there for them, that you are there to support them. You're not going to turn your back on them, that you're there to be their advocate. And just keep reinforcing it. That's the best thing you can do. Eventually, they're going to eventually say, well, I guess I can. And then they'll go and give you a small task to do. And as long as you meet that task, then they'll build up that reinforcement that they can trust.
Okay. So you definitely do see that develops over time with some patients.
Oh, yeah.
Okay. We do have time for some more questions. So if you'll please keep sharing those with Tammy. I've got a few others. So with every patient being different, and some that may be very comfortable with some of the terminology right out of the gate, and others that it may be completely overwhelming, different literacy rates, etc. How do you assess what's going to be the appropriate level for that patient, and then how does that get communicated to other healthcare providers who are working with that patient, so that every healthcare provider, everyone in that patient circle is not starting over from scratch with making that assessment?
So I initially go in and meet the patient and family, and I don't come in saying, you've got this disease and this is the treatment.
Right.
I go in and ask them, so what do you understand? What do you understand is the treatment? What do you understand by what the doctor has taught to you so far?
Right.
Then, if you can pick up on little cues by then, whether they can read, if you hand them a flyer or give them some education materials, a lot of times they're going to come out and say, I don't understand what any of this means. So then I go back, and in my documentation from that patient visit, I put that information in there, so that way the next provider coming in will see it in my note and know. Or also we discuss the patients as a team.
Right. Okay, thank you. All right. Can you talk more about studies that show sugar doesn't feed cancer?
I can. I can't give exact studies, sorry. But this has been talked about for years and years and years. Now, certain cancers, then yes, it would be impactful. Pancreatic cancer, for one, because the pancreas is involved. You don't want that person just overloading with sugar, because that's not going to get processed as well and can cause complications.
Right.
But there has not been anything in any journals that I have found, or any produced literature that says that definitively eating any sugar of any form is going to cause that disease to speed up. So it's a lot of people just like to, I'm trying to find out the best way to say this, but it's not been proven in trials or research, but it's more word of mouth, where a lot of people being healthy eaters, where they want to cut out all your sugar. Of course it is. We do need to cut out a lot of our sugar intake. But if that's the only thing the patient's going to eat, then let them eat it.
Okay, thank you. Have you noticed some types of people, men versus women, cultures, etc., that are reluctant to be treated or deal with the diagnosis?
Yes. There are some, a lot of times it's the lack of trust with the healthcare system. I know at one time, because of the way that Tuskegee Airmen were handled as far as research, a lot of times Afro-American population will not be involved in clinical trials because of that lack of trust. So in those situations, you have to tell them, this is open and honest, we're not hiding anything, and then let them see the process of how it goes through the clinical trial and what everything is involved in each step, and that everybody is going to be, it's not going to be something that they're just going to be guinea pigged on. Everything has to be FDA approved drugs.
Right.
Also, the older population, a lot of times they don't want to be treated. They figure they've lived their life and they just want to move on. They want to not have to deal with the side effects. So there again, you have to educate them whether they want treatment or not. Just ask them, what is the fear, or what makes you be resistant to receiving this treatment?
Right.
Just help us understand. But don't pressure that person. Because if you pressure them, you're going to build up animosity.
Right. No, and that all makes sense. And I can imagine, I mean, they're mentioning Tuskegee Airmen, and there have been real injustices there in the past, and acknowledging that. And there are very real fears about quality of life and what impact. So providing the patients with all the information that you can. Okay, and we've got just probably 2-3 more minutes. So if you do have another question, please go ahead and share that. Let's see, I had 1 or 2 more that I'd written down. If you could talk for another minute about time-sensitive decision-making. So I know you mentioned fertility, and so then that some patients may have to act fairly quickly to do any sort of fertility preservation
Right.
before treatment begins. Are there other decisions that sometimes have to be made in that with some pressure in terms of the time sensitivity?
As far as I know, the only one that is that vastly time sensitive is the fertility preservation.
Okay.
And if you have an aggressive disease, if you have a leukemia lymphoma, sometimes you don't have that ability to have that leeway.
Right.
So you have to move fast.
Okay.
But we have a great fertility group here that I worked with when I was working with sarcoma patients, and they do make things happen fairly quickly.
All right. Well, that's good to hear. Okay, and we'll take just another moment if you have any other questions that you would like to share. What I'll do is I'll go ahead and I'm going to skip on to a couple of other slides, and then I'll come back to our Q&A slide in case anyone else has submitted a question. We do, of course, want to say thank you. We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We also want to thank our team, Mary King, Veneranda Obore, John Powell, for all the hard work they do to make this lecture and every one of our lectures possible. We want to let you know that we've got more events always. We do 24 professional lectures each year, and community college lectures and cancer conversations lectures, lots of different events. Coming up soon, April 24th, Optimal Care for Bladder Cancer Patients, Current Obstacles and Opportunities for Cystectomy Patients, and that's with Dr. Pruthi, and we'll see you hopefully on April 24th for that. And then May 8th, we have a prostate cancer screening lecture. That's an RN and Allied Health lecture with Mark Burge, and I'm not sure I'm pronouncing that name correctly, but Jurlin and Meredith Crabtree. So you can find a schedule of all of our events, unccn.org/events. We do have more self-paced courses. Every one of our lectures like this becomes a self-paced course. You can take that for up to a year after the lecture on your own time, whenever you want, and watch the lecture, complete the test, and if you complete that at a certain rate, you'll go ahead and get the credit for that. And we now have Best of ASH 2018, and we have Prevention of Chronic Postoperative Pain in Cancer Patients. Both of those are now available. Let me jump back to that slide, see if they're okay. Here we go. I worry about overwhelming patients with too much information. How much is too much? Oh, we had that one. It's going to go ahead and load this up again. I'm sorry about that.
That's fine.
So let's see if we've got any others that were added.
Bottom one. Have we done that one? The worry about too much?
Here we go.
Okay.
How can you approach planning for the worst? Okay, no, that is that bottom one. So I worry about overwhelming patients with too much information. So how much is too much? Great question.
Well, you have to watch the patient.
Mm-hmm.
There are clues that the patient will give you when they're starting to get overwhelmed.
Mm-hmm.
They can start pushing back, or they start getting tense. You have to watch the visual cues with the patient.
Gotcha.
What are they showing?
Mm-hmm.
And just tell them, this isn't going to be the only time you're going to hear this from me.
Mm-hmm.
And here's a handout that reinforces everything we've just discussed. And every time you come in for a visit, we're going to go over this. And if you have other questions, that's what I'm here for. We will go over those questions each time you come in.
Right, and I'm sure that overwhelmed is going to vary from visit to visit.
Exactly.
And on an earlier visit, it might not take too much to feel overwhelmed, and then after processing, somebody may come back with lots of questions and be ready to get a lot more.
And also, whenever you're talking with the patient, be sure you're mindful of your body language.
Mm-hmm.
Don't cross your arms. Don't kind of sit rigid. Face the patient. Make eye contact with the patient.
Yeah.
Ask them questions about what you've discussed in small little areas, like discuss what the treatment schedule will be. Mm-hmm. So what questions do you have for me? Mm-hmm. Things like that. That way it keeps the patient more relaxed.
And I like the way, and you mentioned that multiple times, that you're really getting them engaged and asking not just those yes or no questions, but questions that really elicit engagement.
Right.
Okay. All right. Thank you so much to all of you who joined with us today for this and for all the great questions. Last thing I've got to say is thank you for participating. You know where to find us, unccn.org. You can find our newsletter, all sorts of other resources, and lots of lectures coming up this year and beyond. All right, Tim, thank you so much. We really appreciate all your time and expertise today. All right, until next time, thank you so much.